I'd just like to echo the statement that I think medical therapy should also be very high on our treatment for coronary disease before we move into surgery. So I'm going to be talking about off-pump coronary bypass. I'd like to thank Dr. Hanif for inviting me to come and give these talks, and I think he also knows how I feel about this procedure. So I'm going to discuss current outcomes for off-pump coronary bypass grafting, review our current available evidence supporting off-pump bypass as compared to on-pump bypass, and discuss some future directions combining hybrid types of procedures. Now, I'm going to disclose, I don't do off-pump coronary bypass surgery. I do it on-pump, and I think that's why Dr. Hanif asked me to talk about it. He wanted me to review the literature very critically to see what sort of evidence we have. So let's get right to the point. 2013 was sort of a watershed for coronary bypass grafting. Big article in Circulation, also some in New England Journal of Medicine. Should we abandon off-pump coronary bypass grafting? And I'll go through the evidence and hopefully we'll come to a conclusion about that. So let me just set the landscape. Trends over time with off-pump coronary bypass grafting. This sort of resurged in the late 1990s. In a review of the STS database this year, there are over 2 million isolated coronary bypass operations in that database, categorized according to volume of both surgeons and institutions, and looked at the trends for that. What was found by these authors, there's been a progressive decline in the use of off-pump coronary bypass beginning in about 2008. And this actually happened at the higher and intermediate level. So most of the low-level institutions and surgeons did a few cases and didn't change much, but it was the higher ones that saw a decline. And currently, at least in the United States, only about 1 in 5 patients actually has off-pump bypass for their primary operation. So here's the graph that shows that again. Here's the interest that came in the late 1990s, and then a little decline, and then finally in 2008, we're starting to see a progressive decline in its use. So let's talk about the outcomes, early outcomes, and then we'll move into the sort of risk stratification for these operations. So again, 2013 was sort of an era that we critically looked at these operations. The one-year outcomes from the coronary study was a randomized trial, nearly 5,000 patients on and off-pump bypass surgery. No difference, basically, in the primary outcomes, quality of life, and even cognitive function. There is a slightly higher incidence of repeat revascularization in the off-pump group, but that's really not terribly significant. So to stratify here, as time goes on here at a year, basically the outcomes are similar. You really have to drill down quite tightly to see any difference in the outcomes early on. A Michigan study also this year, statewide registry of over 20,000 patients having coronary bypass operations. Again, no difference in operative mortality, but off-pump coronary surgery has a significant reduction in transfusion, reoperation, and things like ventilator time and total ICU time. So again, looking at all the outcomes here from the Michigan database, again, the shift here to the left side favors off-pump coronary bypass surgery for some of the early outcomes. Graft patency has always been an issue with the beating heart type of procedure. So this is a meta-analysis of 12 randomized trials, nearly 4,000 total grafts in each group. There is a higher incidence, we'll acknowledge that, of graft occlusion in the off-pump group. However, this is largely due to saphenous vein graft occlusion, and there's no difference in that all-important left internal mammary artery graft, and we all know that that's the most important factor affecting long-term survival after bypass surgery. So again, here, if you look at the graft patency, the meta-analysis, basically they're equivalent. Multi-center study from 2014 from Denmark. This is a randomized trial comparing on-pump to off-pump coronary bypass grafting. 900 patients, over half of those had post-operative angiography. Again, mirrors the meta-analysis. There's a higher incidence of overall graft patency in the on-pump group, but again, it's largely due to non-LAD distribution graft occlusion or stenosis, primarily vein grafts. So again, focusing here, this is the anterior revascularization, which is usually a left internal mammary artery to the LAD, identical between on and off pump coronary bypass grafting. So let's move into specific patient groups. Okay, diabetics. So the Cleveland Clinic, obviously pioneers in coronary bypass grafting. Retrospective review of their institution's experience, nearly 12,000 patients with primary isolated coronary bypass grafting, similar outcomes, found that risk factors for poor outcome after coronary bypass include deep sternal infection, such as obesity, female gender, and peripheral arterial disease. And these authors recommend not doing extensive arterial grafting, particularly bilateral thoracic artery grafting in these particular patients. And so that may influence the surgeon's operative plan in favor of off-pump coronary bypass grafting. So if you have a patient who's at risk for deep infection, stroke, or other comorbidities, off-pump surgery may offer some benefit. The German group in 2013 did a propensity analysis of about 900 patients with diabetes in isolated coronary bypass grafting. Again, the off-pump group had superior outcomes, improved mortality, fewer strokes, reduced renal failure, and this held out to 1 year for the off-pump group. So again, slightly improved outcomes for off-pump group here. Let's move over to body mass index, obesity. So the Liverpool group this year did a retrospective analysis of their experience in the patients with a body mass index over 30 grams per meter squared. Nearly 4,000 patients compared off and on-pump coronary bypass grafting. Again, in the obese patient favored off-pump coronary bypass grafting with improved long-term survival. The graph here on the left shows that the obese patients here in the blue, better outcomes after off-pump surgery, and again, that extended out to past 1 year. What about if you're thin? So you think those are the great patients to operate on? So the Emory group, pioneers in off-pump coronary bypass surgery, retrospective review of patients at extremes of body mass index, either obese or very thin. Only the patients in this experience that were very thin had benefit from off-pump coronary bypass grafting, and that did extend not only to mortality, but also other outcomes. And it persisted despite sometimes a higher risk profile in these very thin patients. So out here on the left, again, a BMI approaching 15, so very slender, off-pump coronary bypass superior. Low ejection fraction. So the SDS database review of patients with low ejection fraction done in 2013, nearly 25,000 patients compared for off-pump and on-pump coronary bypass, lower mortality, combined adverse events, excuse me. I'll get back here. All right. Lower mortality, combined events, and prolonged ventilation, and importantly, lower transfusion rates in the off-pump group. So again, these differences aren't large, but as you go down the table here, again, you can see re-exploration for hemorrhage, less common in off-pump coronary bypass, a little less atrial fibrillation, and total combined major adverse cardiac events. How about the older patient? So the early outcomes from the randomized trial from Germany, over 2,500 patients, no important differences between off and off-pump coronary bypass surgery, but a slightly higher incidence of repeat revascularization in off-pump, but not terribly different. Again, to see the difference here, you really have to drill down at a very tight level to see any difference. So certainly not worse in the elderly. How about a high-risk patient? So this is a patient that may have multiple risk factors for poor outcome. Propensity analysis using the nationwide inpatient sample from the United States. Over 80,000 patients were compared, 5 different risk groups. Regardless of the type of operation, mortality was similar, but significantly lower neurologic events in the elderly, those with chronic obstructive pulmonary disease, and significant aortic atherosclerosis that favored off-pump coronary bypass grafting. Importantly, from their data, the number of patients needed to operate to show a significant difference of one patient having a stroke was 200 patients. So these are very fine detail and a large number of patients to get the benefit. Now we have, since off-pump coronary bypass surgery has been in use almost 20 years now, beginning in the late 1990s, we now have good long-term outcome data. So this was a meta-analysis done this year of both midterm and long-term outcomes. 32 studies reviewed primary outcomes, survival, and then their usual secondary outcomes. The midterm survival, the two operations basically equivalent. Long-term survival actually does favor on-pump coronary bypass grafting. However, if you drill into these meta-analysis and look only at the randomized trials and the propensity match studies that have a little stronger scientific evidence, there is no substantial difference in the outcomes. And so I'd focus you here. Top here is the randomized trials, and here are the propensity-based. The the stratification lies right in the middle. So the operations are essentially equivalent at long-term outcome. The commentary on this article is particularly enlightening. The authors point out that off-pump coronary bypass surgery is more technically demanding. We know that now with our experience. They recommend that the surgeons that perform this have at least 2 years or more experience, do more than 200 cases to get through what we call the learning curve, and ability to perform off-pump revascularization in the vast majority of the patients without converting to on-pump rescue operations. And then finally, the group from Sweden did a retrospective database review of over 50,000 patients comparing the two types of operations. Similar, obviously, early mortality and now 10-year mortality is basically equivalent between the two operations. There is a slightly improved composite endpoint of mortality and rehospitalization with off-pump coronary bypass surgery. Unfortunately, in Sweden, this is not translated to increased use of off-pump coronary bypass. It's actually translated to less use of that operation. So again, here out to 10 years and starting out to 12 now, divergence slightly favoring off-pump coronary bypass. So now just for the last few minutes, I'd like to transition to where I think maybe off-pump coronary bypass surgery may be heading in the future. There was a multi-center meta-analysis this year comparing minimally invasive off-pump coronary bypass to drug-eluting stents. We've heard a little bit about this in the previous talk. 4 trials, 2 randomized, 2 observational, almost 500 patients in each arms of these various studies. Second-generation stents were used. In all of these studies, minimally invasive off-pump coronary bypass was superior to drug-eluting stents. 2 more studies that cover that, a Korea group, retrospective comparison with 3-vessel coronary disease or left main stenosis, off-pump bypass and drug-eluting stents. About 1,300 patients were matched. Comparative hospital mortality, but again, even at 3 years, so that's early outcomes, superiority in the coronary bypass group, largely due to non-fatal myocardial infarction and then reintervention on target vessels. And then finally, the Korean group did a propensity analysis for left main stenosis, lower hospital mortality, again for off-pump coronary bypass, similar 8-year survival, but superior 8-year freedom. So that's quite long-term outcomes now for off-pump coronary bypass compared to drug-eluting stents. So again, stroke rate a little bit higher in the bypass group initially, but as you go on with time, again, it's revascularization and combined adverse coronary events that lead to superiority of off-pump coronary bypass. Just a brief note about robotic coronary bypass. This is practiced in very few centers, requires a high level of institutional commitment and surgeon commitment to learn these operations. This hasn't been widely adopted, but may be something in the future to consider. In experienced hands, the mammary graft is patent in about 95% of these patients, but again, from the experienced groups showing this significant learning curve, probably about 50 patients before technical expertise is achieved. And then finally, hybrid revascularization. So this is where I think there may be an important role for off-pump coronary bypass in the future. So this is a group from China, a propensity-matched analysis of patients having hybrid off-pump coronary bypass and stenting versus off-pump total coronary bypass. And this was immediate PCI, so mini sternotomy, mammary artery to the LAD, and then immediate intervention in the same setting. I found reduced bleeding at 12 hours and overall transfusion rates, reduced pulmonary complications and ICU parameters in the hybrid group. So this is a graph simply showing their postoperative chest tube drainage, which is obviously reflects transfusion practices as well. And finally, a Canadian group single-center retrospective review of hybrid off-pump coronary bypass and PCI, so not randomized or compared to anything, but about 100 patients. So very minimally invasive robotic mammary harvest, and then a mini thoracotomy for the mammary graft, and then immediate percutaneous intervention. Excellent 5-year outcomes now, over 90% survival, excellent freedom from angina and reintervention. The commentary also from this article is critical to what we do here in our combined heart team approach. The order of revascularization not clearly established, need for a hybrid room, and then obvious costs that may go along with robotic instrumentation. So coming back to the initial point I made when we started, should off-pump coronary bypass grafting be abandoned? I would argue no. I think there is certainly a role for this operation. It is essentially equivalent to on-pump coronary bypass in experienced centers with experienced surgeons. There are certain patient populations that may preferentially be considered and have improved outcomes. Those are those with porcelain or atherosclerotic ascending aortas, liver failure, cirrhosis, extremes of body size, those that have multiple risk factors, and then importantly, avoidance of transfusion. It has been shown in the cardiac surgery literature that each unit that is transfused affects long-term survival, so avoidance of transfusion as possible is important. The advantages and benefits of off-pump coronary bypass grafting, I acknowledge, are modest at best and do require a significant number of patients. The way forward may be for a heart team approach with combined revascularization, and the goal for every patient should be safe and complete revascularization if possible. Thank you.